Thank you. Good morning, everyone. Good morning. Thank you for having me here this morning. As was mentioned, I'll be discussing leukemia. Just a bit of background about myself. I've been here 6 years now, initially from Chicago, and I focus and treat only blood disorders, so benign blood problems and blood cancers. As mentioned, I also am involved at the University of Hawaii Cancer Center. I'm the local primary investigator for the different blood cancer trials that we have open, so that helps to have those options available to patients here and for their families. So today we're talking about leukemia and specifically the types and more recent updates in treatment of leukemia. Some objectives that we'll be going through today are to identify the signs and symptoms of leukemia, differentiate acute leukemias versus chronic leukemias and their subtypes, to assess basic blood tests to help assess what type of leukemia may be present, and to learn about leukemia treatments. So leukemia is a cancer of the white blood cell, and white blood cells are your immune system fighting cell. And there are several different types. Each has its own role in protecting the body from different types of infections. The three most common types are the white blood cell subtypes called neutrophil, lymphocyte, and monocytes. And these attack different infections in different ways. But when a white blood cell count is low, specifically the neutrophil white blood cell, which is your first-line defense for your immune system, the risk of infections and different infectious complications is significantly increased. Red blood cells are the cells that carry oxygen in your body, and the percentage of red blood cells within the blood sample is called hematocrit. The part of the red blood cell that carries oxygen is a protein called hemoglobin, and when the bone marrow is working normally, the red blood cell count and hemoglobin remain normal. However, when these levels are low, that's what is referred to as anemia. So anemia is specifically just low red blood cell or low hemoglobin. Platelets are the cells that help you stop bleeding if you cut or injure yourself. And they basically clog up the hole, and then different proteins and clotting factors seal the hole after that. The bone marrow is the factory for your blood cell. The bone marrow is made up of blood cells at different stages of maturity, and all blood cells in the bone marrow, or all blood cells begin within the bone marrow initially as a stem cell. And stem cells are very immature cells. And when there is need, the stem cells are signaled to grow and develop into more mature white blood cells, red blood cells, and platelet cells. So here's a schematic of what's called hematopoiesis. Hematopoiesis is the development and maturation of blood cells from the early forms, which is the stem cell at the very, very top here. And from there, there's two main groups. On the left is what's called myeloid line, and on the right is the lymphoid line. And these lead to different blood cells, with myeloid line leading to cells here at the bottom. You can look here in the blood. This is where the more mature cells are. So in the bone marrow, top part of the slide, these are all cells that are normally only in the bone marrow, and they're more immature forms. However, when there's certain diseases, we can find them within the blood. But typically, the more mature cells are in the blood, and these include the platelet cells I mentioned, red blood cells, so these come from the myeloid line, and different types of white blood cells, subtypes that fight infection. On the right side is the lymphoid line, and there can be different diseases that occur or different cancers that occur throughout this maturation process as well. At the very bottom are the more mature cells that are the cells that typically are fighting infection and making antibodies, such as the plasma cell makes antibodies, and different diseases and cancers can occur through different points. For example, plasma cells can be a type of cancer called multiple myeloma, which is in the bone marrow. Types that we'll be talking about called chronic lymphocytic leukemia are from this side. Lymphomas are from the lymphoid side, whereas other types of leukemias called myeloid leukemias are from this left-hand side. Here's a depiction of normal blood versus a person that has leukemia. And you can see that on the left side of the normal blood, that's just a normal amount of red blood cells and white blood cells and platelet cells all seen together. However, on the right side, in a person with leukemia, you can see that the white blood cells are significantly increased, and the red blood cells then get crowded out, as do the platelet cells. So that crowding out, what occurs is within the bone marrow, as the white blood cell population increases more than it should, you're left with not enough room to make your other blood cells. You don't have enough room to make your red blood cells or to make your platelet cells, and those cell numbers start to go down just from being crowded out by the leukemia cells that are overtaking the bone marrow. On the left is a depiction of normal ranges of the most common blood test that we use, which is called CBC, which is Complete Blood Count Panel. And this is a test that at least I look at every day. And we look at the amount of the hemoglobin, which is the red blood cell main number we look at the white blood cells, the platelet cells, and then what's also read out is the white blood cell subtypes here on the bottom, which says neutrophil, lymphocyte, monocyte. It gives us different percentages and the total amounts. And that gives us clues when we're seeing a high white blood cell, what's the main cell that's predominating, and gives us ideas of what may be going on. The signs and symptoms of leukemia can include fatigue, weight loss, a loss of appetite, drenching night sweats. So not just the little sweats. I don't want you to be too concerned if you're having a little sweat at night. This is more significant and drenching, where people will need to change their pajamas or clothes. They need to change their sheets in the middle of the night, change pillows and pillowcases. So it's significant, not just a little bit of sweating. Fevers, infections, and abnormal bleeding and bruising, or shortness of breath, specifically if you're anemic. And the CBC, which is the blood count test that we look at from the blood, can either show a very high white blood cell, or sometimes it can even be a very low white blood cell. And that can be from the white blood cells kind of being stuck within the bone marrow, not leading to mature blood cells in the blood on the blood tests. Can be seen with anemia, which is the low red blood cell, and then the name for low platelet cell is called thrombocytopenia. We also can feel enlarged spleen for certain types of leukemias. Certain types of leukemias may have enlarged lymph nodes, which is the lumps and bumps that may be noticed to the neck or under the armpit or the groin area. The gums may be swollen, may be bleeding, and also sometimes leukemia can involve the skin, and we can see a rash that's called leukemia cutis that we can biopsy and prove that we can see leukemia cells within the skin. There are different types of leukemias, and we'll be going over this several times. The first type listed here are the acute leukemia types. The first one says acute lymphoblastic leukemia. We call this ALL for short. This is the most common form of leukemia in children. AML is called acute myelogenous or acute myeloid leukemia. This is the most common form of acute leukemia overall, affecting more so adults than children. CLL, which is chronic lymphocytic leukemia, is the most prevalent form of chronic leukemia in adults. And lastly is CML, chronic myeloid leukemia or myelogenous leukemia. And this mainly affects adults and may produce few or no symptoms for months or even years. But specifically, there's a certain chromosome change that we see, which I'll be discussing later. You can see the pictures here. The acute leukemia forms ALL and AML. The blood cells are bigger. These white blood cells are, you can see, bigger than the red blood cells next to them, whereas on the chronic forms, the white blood cells are about the same size. And that has to do with their maturity. So the more immature cells are larger and can be stickier, and when they're larger and stickier, they can cause more problems such as blood clots and the blood being too thick. And that can affect the circulation to certain organs. Here's a slide listing some characteristics of the major subtypes. It's worth noting, the year down here says 2005, and That is important to note because 2005 is nearly 20 years ago, hard to believe now. But some of these numbers are different now, and it's kind of interesting for me to see this and think of how far we've come, especially for the form called CML, chronic myeloid leukemia. Sorry, I'm having some trouble with the laser today. Here it says poor prognosis. These days we would not consider this a poor prognosis. We would consider this a favorable prognosis, in that patients with CML, chronic myeloid leukemia, now typically live a normal life expectancy just with pill treatment. But ALL, as mentioned, 75% occurs in children, so that's the most common form of leukemia in children. They continue to have a very good prognosis with cure rates over 90%. ALL is seen also in adults, but when seen in the non-pediatric population, the prognosis is not as good. And the prognosis is worse in older adults and worse in the elderly compared to middle-aged people. Acute myeloid leukemia occurs in 85% of the time in adults rather than 15% in children. And prognosis is variable with it. CLL, chronic lymphocytic leukemia, typically only occurs in adults. And the prognosis is very dependent on the stage that we'll be talking about later. I think they flipped the numbers here on this. For stage 1, it says 19 months. Stage 4 says 12 years. That should be flipped. But overall, good prognosis. And then CML, I mentioned, 2005, they listed it as poor prognosis, but now it'd be very favorable prognosis. So when someone is diagnosed with cancer, the first question that we often get from the patient or their family is, what stage am I? Because they know that stage is important in determining their treatment and overall prognosis. It's interesting in that most forms of leukemia, we don't use stage. So there's not a stage 1 acute leukemia or a stage 4 acute leukemia. We really only stage chronic lymphocytic leukemia, or CLL. But in the cases where we don't use stages, we use risk groups, and we're able to risk stratify patients into favorable risk groups or intermediate risk groups or poor risk groups. And that's similar to staging, although just a little bit different in the terminology. But for the type of leukemia that we do stage, called CLL, chronic lymphocytic leukemia, it ranges from stage 0 to stage 4. And stage 0 means that we just see the white blood cell count elevation in the blood without any other problems. This is early stage. Stage 1 is still considered early stage, and this is, we feel, enlarged lymph nodes throughout the body that are swollen with the leukemia cells. Stage 2 would be that plus an enlarged spleen. So the spleen is the organ that sits in the left upper part of your abdomen, just under your diaphragm, and typically we can't feel it at all, but if we can feel it, that means it's enlarged. And then stage 3 or 4 is more advanced stage, and this is where it's really affecting the bone marrow production, and that we can see anemia, which is low red blood cell counts, and stage 4 would be low platelet cell count, again, due to that crowding out of the bone marrow when it's more advanced. So to focus a bit more on acute leukemia is a cancer of the white blood cell that's at its most immature form. And the cell that we refer to as read out on the blood count tests are called blast cells. And blast cells are very large, immature cells that are not typically seen in the blood count test. So if we ever see a blast cell being reported, we know it's an abnormality that we need to at least investigate or repeat if it's at low numbers, but if it's at high numbers, it's very consistent with acute leukemia. This condition can progress very rapidly, creating a large number of abnormal white blood cells, and they don't function normally, and they don't mature properly. Symptoms tend to appear earlier and to be more aggressive than symptoms of chronic leukemias. So for instance, patients can be completely normal 3 months earlier, doing all of their normal life activities, normal energy level, and then over the course of just a month or weeks, really progress quickly to be very tired, short of breath, losing weight, can have bleeding problems and infections. So acute leukemias, patients are commonly diagnosed in the emergency room when they come in with those types of symptoms that kind of just started just within the past weeks. There's different classifications for the different types of acute leukemias. The modern classifications that we use these days look at certain chromosome changes and molecular or mutation alterations. I mentioned that we use risk groups to risk stratify these cases. There are certain specifics that we look at with each type. So for acute lymphoblastic leukemia, we also assess for a certain chromosome change that's called Philadelphia chromosome. That was discovered in Philadelphia. That's a change between chromosome 9 and 22 becoming together, and that's synonymous with the two genes called BCR and ABL. There's another more rare form of leukemia called APL that's classified separately. It has a very good prognosis of over 90% cure rates in adults as well. The older classifications that we don't use anymore did not use chromosomes and mutations and molecular changes to identify and classify these forms of leukemia. Before, they just looked under the microscope and said, this is what it looks like, and described it, and was classified in that manner. This is an example. Don't worry, you don't have to memorize this. There will not be a test at the end of the talk. Even I have to reference this. So this is the classification for AML, acute myeloid leukemia. And you can just see the list here of the different mutations that are seen and different chromosome changes that are seen that change what group a person may be classified in with leukemia if they have favorable, intermediate, or poor risk disease. There are several different prognostic factors for people that have acute leukemia. These include age, performance status, or functional status, which means what's their baseline functional status. Are they moving around independent? They're taking care of themselves, they're able to work, or are they more frail, more bedbound? Those factors have a big factor in terms of the treatments that we can use and their overall prognosis. I mentioned the chromosomes and mutation changes. We stratify into different risk groups. If people have had a prior exposure to treatments such as chemotherapy or radiation, that typically incurs a worse prognosis, and that leukemias can develop from such treatments in rare cases, and they can be more resistant to treatments. Similarly, people that have an existing blood or bone marrow disorder that then changes or transforms into a different form of leukemia also have a usual worse prognosis. Long-term survival has improved overall in the younger age population, and more recent years has also improved in the older patient population. There's no age cutoffs that we use specifically. We have to look at each individual. But long-term survival and cure rate in younger adults with different forms of leukemias, it's a general statement, is typically around 40 to 50%. In older people where we may not be able to use as intensive treatments, the cure rate is much lower, but we can extend their survival and hopefully quality of life. Here's an example of the different risk groups in terms of the different prognosis that you can see is quite different with the different favorable, intermediate, or adverse or poor risk groups in terms of their long-term survival. And you can see in the favorable risk group, long-term survival at 4 or 5 years is around 75-ish%. Intermediate's more around the 50-ish% range, whereas poor risk is typically lower, around 20 or 25%. Touching on the chronic forms of leukemia, this is due to an overproduction of the more mature blood cell type, and it inhibits the development of blood stem cells, ultimately causing them to function less effectively than the mature, healthy blood cells. And this tends to be less severe and progresses more slowly compared to acute leukemias. As the cancer progresses and spreads, symptoms may appear later on. So for this group of patients, this is oftentimes diagnosed just on routine blood tests. A person may be feeling completely normal, but is following with their primary care doctor and has a blood test and shows a high white blood cell count that then prompts further workup. Chronic myeloid leukemia has a characteristic chromosomal alteration. I mentioned this Philadelphia chromosome earlier, which is sometimes seen in ALL. It's always seen in CML. There's some other more rare types of leukemias that we don't see nearly as often. One type is called hairy cell leukemia, and that's just a description of how the cell actually looks with these different projections that are seen on the blood smear when we look under the microscope with spikes. On the right side is MDS, or myelodysplastic syndrome. This is a group of diseases in which the bone marrow does not produce enough healthy blood cells, and it's typically an issue with a maturation process with the cells getting stuck in their more immature forms. This is sometimes referred to as pre-leukemia because it can progress to acute leukemia in some people later. And another group of disorders is called myeloproliferative neoplasms, and this is a group of multiple types of other blood diseases, and this is a group of slow-growing blood cells in which the bone marrow is making too many abnormal red blood cells, white blood cells, or platelet cells, depending on the disease. And you can see here there's different mutations that are associated with each type.
What is multiple myeloma?
Multiple myeloma is not considered leukemia. So multiple myeloma is a different bone marrow cancer, and it's a cancer of the blood cell that makes your antibodies. And we can measure those antibody levels in the blood to first at diagnosis and then later on with treatment. So it's a bone marrow cancer, but it's not considered leukemia. There's different testing that we perform in a patient that has leukemia, and its evaluation and workup. I mentioned already chromosome testing and mutation testing. We also perform a procedure called bone marrow biopsy that I'll show a picture of later. And then also we use a test that's called flow cytometry. Flow cytometry is a special type of blood test that looks at the markers on the blood cells. And it can give us an idea of kind of their fingerprint to really tell us what type of cell is this more specifically than just looking under the microscope. Other tests that we consider are imaging tests for different forms. So these may include X-rays or CT scans, or a special scan called a PET scan that lights up using a radioactive sugar molecule where tissues and cancers are more active. This can sometimes reveal enlarged lymph nodes or masses or enlarged spleen or also signs of infection. In some cases, but not all cases, we also perform a spinal tap, or what's called lumbar puncture, and this is a sample of the spinal fluid, which is the fluid that fills the space around the brain and around the spinal cord. And in some leukemias, people can be at higher risk for having leukemia cells within the central nervous system, and this is how we test for that. And depicted here is a bone marrow aspiration and biopsy, which is a sample of tissue obtained from the hip or the pelvic bone. That can be looking at the factory for the blood cells. And we can get a lot of information from the blood, but there's certain things that we cannot get from the blood that we can only get from the bone marrow. And this is when we have to perform this type of procedure. This is an outpatient procedure. People are awake during the procedure. We numb up the area well. In general, people tell me after the procedure that I thought it was going to be much worse. Bone marrow biopsy does not sound like a pleasant experience. I'm not saying it is a pleasant experience, but we do try to make the person most comfortable. In some cases, it's something that they'll have to get multiple times throughout their treatment course to reevaluate their disease. We take fluid out, and then we take a core needle biopsy, which is a small 1 or 2 centimeter piece that's a narrow, less than the size or the diameter of a pen. Some people like to look at it after we take it from them and say, what were you doing back there? Some people definitely don't want to see it. These are some of the characteristics that we test for with different diseases. Different mutations are seen in different diseases, so the specifics always are important. And next we're going to be talking about treatment. So the treatment for leukemia varies based on its type and the specific characteristics, so even one diagnosis is not treated the same for each individual. Early and accurate diagnosis is important to achieve the best possible outcome and quality of life. That's more so important in the acute leukemia types that can be very quick acting in terms of how quickly they can produce issues and problems. Some of the chronic leukemias may not even need treatment, and therefore early diagnosis doesn't change things too much. For acute leukemias, in terms of therapies, we separate people into two main groups. It's the older and more unfit group and the younger and fit group. And like I said, it's not an age cutoff, but more so a function of their activity level and how strong we think they are in terms of what treatments they may be able to withstand versus which treatments may cause more harm than good. So first, in the younger and fit group, some ages that we think about, but there's no actual cutoffs. So certainly people younger than 60 are considered younger group, and then usually 60s to younger 70s we consider, but there's no one cutoff. In these younger people, we are treating with more intensive treatments. And these intensive treatments are intensive because we're trying to cure the leukemia. And they're more intensive and lead to more side effects, which is why fitness level and age can be a factor in terms of making that decision. We consider using intensive induction chemotherapy. It's usually given in the hospital. And this is typically given in the hospital. People are usually in the hospital for around 1 month. So when they come to the hospital, they may not even know what diagnosis they have if they're coming to the emergency room. And that's something that we try to tell them up front when we're suspecting this, is that they'll be in the hospital for a long time. When you get a diagnosis and then start treatment. And the reason they're in the hospital so long is that treatment itself is a continuous treatment in often cases for about a week or so, but then the blood count goes all the way down to 0. And the white blood cell stays at 0 for weeks. And infection risk and need for blood transfusions is needed throughout that time period until things improve and then the patient can leave the hospital. We use intensive treatments even after that first cycle as well, and then we also consider things called a stem cell or bone marrow transplant, which is a very intensive procedure. We also, in different forms, use prolonged maintenance, even 3 years of treatment for forms called ALL. And I mentioned that ALL, we look at that certain chromosome change. So if we see that chromosome change, we add in a pill that targets that certain chromosome change. It's a very important part of that treatment, which has significantly improved the prognosis and treatment for those patients. In the older or unfit patients that we don't think are able to go through that intensive type of treatment, the treatment is, depending on the type, not curative, but more so getting the disease under control, can still get the disease in remission, but typically not cured. And in cases where the disease is very advanced or the person is in very bad shape, we consider things like supportive care or hospice care. The treatments that we use for this type of group is more gentle, I guess. More gentle and a less intense form of chemotherapy. These are treatments that are able to be given outside of the hospital and often in combination with pill therapy at the same time. And this combination has really improved our outcomes in recent years. For ALL, we look at, see if that chromosome change is present. If so, we may just give that pill alone or may give that pill with other leukemia fighting types of therapies, including chemotherapies or immunotherapies. For an idea just to see the different mutations that we see for the form called acute myeloid leukemia, there are some mutations that are more common than others, and that's what's seen on the left side of this graph is the more common mutations. You can see have the higher bar. On the right is a depiction that's called a ribbon diagram, and this is showing that some patients have multiple mutations at the same time. And the wider ribbon, these are more commonly seen. So it's not just a simple one mutation, but there can be multiple different mutations that are present at the same time. And there are 3 specific mutations that we have specific pills that can target these specific mutations, and that's also more individualized for the treatment of that patient. So these specific mutations that are targetable with pills are able to be given orally, which is, of course, more convenient than IVs or subcutaneous injections. And there's more and more pills that are becoming available over these years that target these specific mutations to help to treat their leukemia in different settings. Sometimes the FDA has it approved for the front line, which means just when you're diagnosed, you can start that. Some are approved for what's called second line, which means you've had a treatment before, and then the cancer has either progressed or it hasn't responded well, and then eligible to receive it as second line treatment from the FDA. Other more recent treatment advances throughout these different types of leukemias. One type is a chemotherapy but connected to an antibody, and this is called inotuzumab ozogamicin. This is used in relapse refractory, which means not front line, but in second line or later types of ALL therapies. And this is an antibody, and we all make antibodies on our own immune system, but this is an antibody made in the lab, and it on the first end here, it targets a marker that lives on the white blood cell for the leukemia cell, and these red star types of circles are chemotherapy that's attached to the antibody. So the antibody is directly targeted to the specific cell that we're trying to kill. So it's kind of targeted form of chemotherapy. It has less side effects because it goes to that area rather than throughout the entire body. There's other forms of treatments that we're going to be talking about called CAR T cells. There's multiple different products available for different leukemias, lymphomas, and multiple myeloma. And there's another immune therapy called blinatumomab that's approved for ALL as well. So this is a depiction of the treatment that's called blinatumomab, and this is an interesting engineering feat for 2 different types of antibodies that are being attached to each other to really help your immune system kill the cancer cell. So here we use 2 different forms of the antibody, but just kind of their business end. So the end that's doing the targeting, and it brings together on one side your own body's white blood cell called T cell, and on the other side is the marker that's on the leukemia cell. So it's this linker that brings your own blood cells next to each other to have your own T cell kill your leukemia cell. And there's more types of these treatments available now. For the treatments of chronic leukemia, for CLL, we used to use chemotherapy and only chemotherapy, but over recent years, we hardly ever use chemotherapy now, and now it's more so targeted pills with or without an antibody that targets a marker on the white blood cell, so it's much more tolerable and also works much better. For CML, this is the chronic myeloid leukemia form. This is the form that I mentioned earlier, has been revolutionized from the pills that target the marker for this Philadelphia chromosome, and typically the prognosis in most people is equivalent to their age-matched partners with good prognosis. We used to, until just recently, say that once you started this treatment, you need to be on it for life. But just in the past 3 or so years, we've been able to stop these treatments after being on these pills at least for 3 years in people that have no detection of their leukemia. And there's more and more types of these pills, and another pill was approved in the end of 2021 that's better tolerated and maybe moved up to front line. Currently, it's in third line. So here is CAR T cells. So what are CAR T cells? CAR T cell stands for chimeric antigen receptor T cell. So chimeric typically is a connection of 2 different things, and these are your own T cells. So your own immune system cells get engineered to target the cancer cells using a specific marker. So your T cells are combined with this receptor that sits on the surface of the T cell that then is infused back into the patient, and that's depicted here. So the first step is a patient has their white blood cells taken from them, called leukapheresis. And then these blood cells get sent to a lab, a special lab, where certain viruses are used to induce this new marker on the T cell. And these T cells have to grow in the lab for a couple weeks. And then those T cells are able to be then shipped back to the facility where the patient is. And right before the patient receives those CAR T cells, they receive a one-time dose of chemotherapy. And that chemotherapy is a relatively lower dose to help eliminate some of their own T cells that they have within their body before they receive these new engineered T cells. So it's basically like a living drug that from your own immune system. There are several notable side effects for these specific types of CAR T cells. Most notably are increases in your immune system and overactivation of your immune system called cytokine release syndrome, which is fevers and low blood pressure or shortness of breath. That inflammation can also cause what's called neurotoxicity, which is alterations in your nervous system, which can be things like temporary trouble speaking, or can have even more severe cases, things like seizures or even coma, things like that. So they can be very scary to see. You know, if someone we're seeing them, they're normal, and the next day they can hardly speak to their spouse, can be very concerning. The good news is that these are temporary and not long-term. And once the immune system calms down, and with treatments to calm down the immune system, these things improve. The applicability depends on the target, so we can't use targets for everything just yet, but currently the approved products are for B-cell markers, so B-cell leukemias, and also for multiple myeloma. Lastly, I want to talk about stem cell transplant. So what is stem cell transplant? So stem cell transplant is the same thing as bone marrow transplant. You'll maybe hear these two different words, but they're used interchangeably these days. This is a replacement for the recipient's bone marrow stem cells with either their own stem cells that we stored earlier or from a donor. So from themselves is called an auto or autologous stem cell transplant. From a donor is called an allo or allogeneic stem cell transplant. The vast majority of cases, we do collect the stem cells from the blood. We don't harvest from the bone marrow like was done many years ago. And this is done by first mobilizing the cells and then collecting them. So here is a depiction of the two different types. So this is the autologous stem cell transplant. So first, the stem cells are mobilized. And mobilized means the cells move from the bone marrow into the blood. And that allows the collection of the stem cells then from the blood. And those cells are then processed and typically frozen. And then the patient themselves undergoes a treatment to basically wipe out their bone marrow. So an intensive type of treatment with chemotherapy with or without radiation. And the main purpose of this transplant is described here. The treatment benefit is really the chemotherapy or radiation. That's the treatment that's given before you get your stem cells back. As the transplant's really just a stem cell rescue. What I mean by that is if we gave such an intensive treatment without giving your stem cells back, your bone marrow would not recover and the person would pass away from bone marrow failure. But with this type of technique, we're able to give that high intensity treatment but then give their own stem cells back. And those stem cells then are like planting the seeds, and their own bone marrow then returns. But it does take time for recovery, and your immune system is like a newborn baby again, and you have to get all your vaccines again. So it's a whole process. Believe it or not, that's less complicated than the allogeneic. Allogeneic is even more complicated process because here the donor, which can be a family member or can be a person that's completely unrelated to you on an international registry, we use their stem cells and give them to the patient. And here, the treatment benefit is not just the chemotherapy radiation, but it's the new immune system. And the new immune system is called graft versus tumor. So the graft is the stem cells from the donor graft versus the tumor effect. And the reason this can occur is because the immune systems are different. We want the immune systems to be similar enough to try to avoid things called graft versus host disease, but also are different enough in that they recognize the leukemia as foreign and kill the leukemia. Here is a depiction of how often different types are used. The green being autologous, which means from their own stem cells, and the blue being allogeneic from a donor. And you can see different diseases, we use different types. So for leukemias, we usually use the types from a donor, whereas for lymphomas and multiple myelomas, more so the types from their own stem cells. And from the donor type, those donor types have changed over the years of different techniques have been able to better use less matched people. So before it used to be just siblings that were able to be fully matched could really be donors, but now we have other modalities to have unrelated people and even just half matches. Half matches are called haplo, which can be from a child who's a half match, or a parent could be a half match, or even siblings may not be a full match, but may be a half match. There are several complications of stem cell transplant, most notable being low blood cell counts for a prolonged period of time, so the risk of infection and bleeding and need for blood transfusions, but other inflammation, and I mentioned graft versus host disease, only seen in allogeneic transplant. So I wanted to leave you with one homework assignment, and that is to review patient resources that are available online. A good group is called Leukemia Lymphoma Society, and they have different educational pieces of information, but a lot of websites have good information. But I think what separates some groups apart from others is the other resources that they're able to offer, and that can be financial resources to patients and their families, can be connecting with other patients that have the same disease, or for the caregivers to connect, or look for clinical trials that are available. So it's a good resource, not just information read, but really making connections. So I'm happy to take questions. Thank you.
Yeah, are there special blood tests that you have to take in order to find out whether you have abnormal count of white, red, and platelets? Because I take, blood tests every year for, A1C and the rest of the thing. But I'm just wondering what blood tests would show that.
So that's a good question. So when a person gets a blood test, it's only the tests that are specifically ordered, right? It doesn't test for every single thing, which some people may not realize when they're having their test done. They think that it's checking for everything, and it's really just checking what's ordered. So I think what's commonly ordered are things like cholesterol, looking at your kidney function with chemistry tests. A1C is for diabetes, checking to see if people are at risk or following that. And CBC is the name for this blood test. So CBC, which is still a basic blood test that's commonly done, may not be done all of the time, but it is one of the more general tests that are commonly done. So CBC would be the test that looks at the blood cell types.
So that would be sort of like the beginning. I mean, if
Correct.
anything's wrong, and then you go on, but that's sort of the basic test.
Yeah, the question was, is that the basic beginning test? And that would be yes. So if there's abnormalities on that test, then we can do other tests that kind of sort out what's going on.
Paid for by insurance.
CBCs should be covered by insurance, and then the subsequent test depends on, I'm not the insurance company, I can't tell you what's covered or not, but typically would be covered, when it's done appropriately, yes. You're welcome. Other questions? Yes.
Do the genetic mutations that you identified do they cause leukemia, or does leukemia cause those genetic mutations?
So that's a very good question, and words like mutations and genetics can be confusing to know, is this something I was born with, or is this something developed later in life? And in most cases with blood cancers, it's things that develop later in life. Years ago, we used to think that hardly any type of blood cancers ran in families or hereditary, but now we're learning more and more as we're doing more mutation tests. And still a small number, maybe 5–10% of cases are higher risk with hereditary issues. But most of these mutations are occurring early on in the disease process. And it's not just typically one mutation that causes the leukemia, but multiple kind of hits. So over time, you may have one mutation that occurs, and then years or decades later, another that occurs in that same cell, and then they start to add up and cause more problems and then cause a cancer. Welcome. Yes?
Are there any food additives that you avoid because you don't want any genetic mutations, or any areas you would not live in, for example, because of the environmental situation?
So cause is always a question that is a very logical question to ask, and a natural thing to say, why did I develop this disease? It can oftentimes be an unsatisfying kind of answer in terms of saying specifically what may have caused one individual's cancer, in this form leukemia, but there are certain risk factors that we worry about. Certainly radiation exposures can increase the risk for leukemia. Certain chemicals can increase the risk of leukemia, like benzene, that's an industrial product, but also in other things like smoke and not too many places in the natural environment. For other blood cancers, specifically lymphomas and multiple myeloma, we worry more about things like pesticides. Certain pesticides can increase risks. In general, in terms of diet, I would try to focus on a diet high in vegetables and fruits, good antioxidants, especially in fruits, and then trying to minimize processed foods as best as possible. Higher intake of things like red meat is more so associated with higher risk of GI type of cancers like colon cancer and things, but not so much leukemia. For specific foods, there's one study that I know of for chronic lymphocytic leukemia, a slower growing form of leukemia, that looked at patients that had early stage, not yet on treatment, and was shown that olive oil was helpful in terms of delaying when that group needed treatment or not. So healthy fats are good for your diet as well. Good question.
When I worked at St. Jude's Children's Research Hospital in Memphis, the outlook for the kids with leukemia was very poor. But then they discovered that the cancer cells were hiding in the brain and the testes, and so they started radiating those areas. So I was curious, is that still the same treatment? And also in older adults, are there certain places where you think they hide and then cause a relapse?
Very good question. So ALL specifically, so acute lymphoblastic leukemia, is the form most common in children, and there's been different iterations of the treatment paradigms that are used, and over these decades, different parts have been incorporated, and a lot of that incorporation has included what's called central nervous system prophylaxis, which is even if they don't have leukemia that's detectable within their brain or spinal fluid, we treat that area knowing that that's a high risk of relapse to that area. That the other reason is the treatments don't typically get into those areas too well, so they're kind of protected sites. Your brain and your spinal cord are designed in a way to try to keep things out of the brain and the spinal fluid in terms of infections, but it also keeps medications and drugs out. So there's only specific types of treatments that really get into the brain and the spinal fluid that are incorporated in these treatment regimens. And it's used more and more in ALL specifically. some types have lower risk of brain or spinal fluid involvement. So AML has a much lower chance of that compared to ALL. In terms of irradiation, these days it's based a lot on the initial testing. So including looking at, is there any minuscule amount detected with special tests, like things called flow cytometry, to really determine if there's, how aggressive one needs to be in terms of this treatment against those areas. So it can be personalized a bit more. But everybody for ALL receives some amount of brain or spinal fluid treatment, even as prevention.
Two-part question. One part answered with yes, no, other part more
Noted,
words.
noted.
So the yes, no is, should everyone in this room ask their doctor for a CBC test? And then part two is more curiosity type. What makes what does leukemia do to give you these drenching sweats and lose weight and bleeding gums? Why does that happen? That's the longer question.
I wish your yes, no was as easy as a yes, no. I mean, from a hematologist side, I look at CBCs every day. So I would say that there's not a general recommendation that everybody must have a CBC. I think it's reasonable to ask, if you've never had one, to have one checked so you kind of know at least what your baseline is. I see some people that are diagnosed, and the first thing I'm doing is I'm looking back to see how does it compare to their last CBC. And sometimes they may have had a CBC, within 3 months or a year ago, but other times, 7, 10 years ago or never. And it's more helpful for me to be able to compare, especially for the slower growing types, because, you may have had it for years even and just not known about it. So I would lean towards yes.
I can tell you as a geriatrician, in the primary care setting, we have a very low threshold for doing CBCs. So a lot of people will get a CBC done because it can uncover so many different things. But it's not routinely done. It's not like you'll get it once a year or whatever. But I think chances are many of you will probably have had it.
It's
even
one
if
of the
you
most
don't.
basic
Yeah.
blood tests
Yeah.
that doctors use. The second question, to answer that, so a lot of it has to do with your inflammation within the body and the different inflammatory molecules that are made by the cancers themselves. So there's things called cytokines that are a type of chemical that's made that really revs up your inflammatory response. The bleeding gums can be actually leukemia involves the gums, and the gums become thickened and swollen. And the bleeding comes in, especially if the platelet count is too low. Although sometimes the platelet count can be normal, and your body can be eating up all of its coagulation factors, or the clotting factors. And if the clotting factors are too low, then you're at high risk for bleeding too. So there's not just one reason, but depends on the case.
Just a first quick thing about the CBC. I'm a relatively healthy person, and whenever I've had physicals over the last, 20 plus years, I've always had a CBC. And it's just a good baseline to have. And then, I get kind of paranoid when I see the numbers fluctuate, and, even by a little thing, and the doctor's like, you're fine. But, so I think it's just a matter of asking for that. The second thing is that you said that acute leukemia is usually diagnosed in the ER. So somebody comes into the ER with some symptoms, which are they the ones you talk about, the sweats, the gums? I mean, that could be almost anything else, but then I assume then it's diagnosed with a CBC or some other blood test. But what are the most common symptoms that you would end up seeing in the ER? Or I would want to send somebody to the ER because something doesn't look right.
So it could be new unexpected bleeding. That could be internal bleeding. It could be bleeding in the stool. It could be severe weakness and exhaustion, and the patient's unable to get out of bed. It can be significant shortness of breath. That's shortness of breath or chest pain that leads someone to go to the ER. So it's not that we like to make the diagnosis in the ER. It's more so that it's a relatively sudden onset, and that's a common way for people to present. So they're significant symptoms, not subtle symptoms in acute leukemia. And the CBC is the initial test done, which is done in the majority of patients in the ER, I would say. And that gives us the first clue and can compare to a prior CBC if performed, but significant changes in the white blood cell would be the major tip-off. Yes.
I was told that oxygen, the cancer does not like oxygen, and there's some supplements that also retard the growth of cancer. Can you tell us some of the supplements? It's vitamin D and things like that, or heat therapy, which increases oxygen to the tissue. Does this help retard cancer?
That's a good question. So our normal tissues need oxygen too. So that's an important thing to realize. So don't be depriving yourself of oxygen too much. So different, cancer is so many different diseases. And it's not one disease, but it's hundreds or thousands of diseases. And each specific cancer has its own characteristics that stimulate it or help the cancer to grow. For leukemia, oxygen isn't one that we typically think of. These are blood cells that are usually freely floating throughout your body and not one tumor, like is more common in solid tumor cases like a breast cancer or lung cancer, where circulation to that tumor is trying to be produced by the cancer to help it grow. So it's different in different types. I don't know of one specific supplement to answer your question, but I would say that antioxidants are important in terms of cancer prevention. But if a patient is on treatment, it's always best to talk to the treating doctor and making sure what supplements someone may be taking, because there may be interactions and we want to limit those interactions that could be decreasing or increasing too much the other medications that are being taken. So it's always important to let the team know, including the pharmacists that are working with them, to see if there's any interactions. But sorry, I can't answer your question more specifically on this case.
Thank you so much, Dr. Boddy.
Welcome.
Oh, do we have one more question? Okay, one last question.
Yes.
Okay, I was just looking back at my most recent complete blood count, and I noticed they don't have as many things as you have in your table here. In other words,
So there's two types.
okay,
So there's one, and I pulled this up when one of the prior questions. So some is just this top portion, and that's called a CBC without diff. And diff means differential, and differential is a differential of the white blood cell. So without diff would mean you just get the WBC, which is the white blood cell total amount. Differential gives you the percentages and the absolute numbers of these different white blood cell subtypes. So it's more so important to get the differential if you have an abnormal white blood cell total number.
Thank you again. That was wonderful. Very, very informative.